So without further ado, lung cancer management in North Carolina. It's February 25th, 2026, and Jared Weiss, MD, will be presenting. Uh, there we go. There's a bio, but we're going to break it down for you here. So Dr. Weiss is a professor of medicine in the Division of Oncology at UNC Chapel Hill. His clinical practice is focused on lung cancer and head and neck cancer. He favors oral targeted therapies or immunotherapies when possible, and he is passionate about maximization of quality of life. His research is focused on personalized and adaptive immunotherapy to treat cancer, neoantigen cancer vaccines, and cellular therapeutics. And he has particular interest in small cell lung cancer and NUT carcinoma. Dr. Weiss, welcome. So glad to have you here today.
Thanks for having me.
Absolutely. What's one thing we should know about you outside of your impressive professional bio?
I have three wonderful daughters who are the joy of my life.
Wow. Well, good for you. Good for you. All right. Well, let's go ahead and ask our first poll everywhere. This is always kind of a softball. What is the most common cause of cancer death in a never smoker? And we'll put that up and give you all a few seconds, although I think folks are going to be pretty quick on this one. We've got a 100% sitting on lung cancer, even for the never smokers. How are they doing?
That's exactly right, unfortunately. Lung cancer is underrepresented in funding dramatically when assessed per death. And unfortunately, due to late presentation, typically in stage four, this is unfortunately true, both in smokers and in never smokers. It's the leading cause of death.
All right. Well, let's turn it over to you to find out more about this lung cancer management in North Carolina. We'll let you take it away.
So I don't think I have any conflict of interest directly relevant to our content, but my full COI is available live and updated on the ASCO webpage. This is a 45-minute to an hour talk, and so obviously I can't be comprehensive here. It would be completely impossible thanks to the wonderful speed of advances that we've had in the last few years. So I've chosen to focus the talk in a few ways. I want to start with some North Carolina specific information since that was put in the title of what I was requested, Lung Cancer Management in North Carolina. I want to focus on things that are immediately applicable to practice or about to be applicable to practice. So approvals within the last 3 years and things that I think there's very good visibility to approval within the next year or two. I'm going to focus on themes. So advances that are good, not just in and of themselves, but show a principle of where related therapeutics might be going. And I'm certainly not attempting to be comprehensive. The last thing I'll say here is that we have a mostly non-physician audience, but a really wide range of specialty levels of folks on here. So every time I've given these before, I've gotten the feedback that it was both too technical and not technical enough. I'm going to do my best to show the full, rich data, but translate it into English a bit. So starting with incidence of lung cancer here in North Carolina, we're about average, actually, 62 per 100,000 people, just slightly higher than the national average at 52.8, and making us 41st amongst the 50 states. Orange, by the way, in this and the following slides are us. Green are the averages. And so we come to a polling question. The American Lung Association calls for the following actions to be taken by North Carolina. Are they saying that we should raise the legal age to sell tobacco products to 21? That we should increase cigarette tax? That we should increase funding for North Carolina Tobacco Prevention and Control Program, or all of the above? And I'm not going to dwell on this one. This one's kind of a give me. All of the above would be helpful. The best way to reduce suffering from lung cancer is to prevent it, to not have it happen in the first place. Roughly 70% of lung cancer is caused by smoking. No one deserves it, of course, whether they've smoked, never smoked, former smoked, but that is the statistic. Interestingly, that's evenly divided, with 15% of that 30, so half on an absolute basis, on a relative basis, having never smoked, and another 15% who've smoked, but that has nothing to do with why they got lung cancer. There's nothing about smoking that protects you against the non-smoking biology. We're all constantly breathing in mutagens and carcinogens. Even oxygen can cause mutations. So the American Lung Association mostly gives us Fs for tobacco control, and all of those are their suggestions for what we should do to improve. For 5-year survival from lung cancer, we are 21st out of 39 states with data, so a little bit below average. But our 5-year survival has improved by 25% over 5 years. This comes both from advances in treatment and advances in screening. So some may know this data well. This is the National Lung Screening Trial. And the x-axis here are years since randomization. Y-axis is cumulative lung cancer deaths. And what happened in this trial is that patients were randomized to the experimental arm of low-dose CT or to the experimental arm of chest X-ray, which we know now is from other data to be a socially palatable placebo. You don't prevent deaths with chest X-rays alone. And there's a real reduction in lung cancer death from doing this. And all of the major guidelines tell us to do it. At right, you have the bullets of who should be screened. It's a little different by guidelines to guidelines. Many of us believe this should be liberalized, but here's a reasonable place to start with. People who are 50 to 80 years old, at least 20 pack years of smoking, and currently smoke or quit in the last 15 years. That defines a risk level that is considered screenable. The screening in the study was every 3 years, although there really wasn't as much fall off as you would think in diagnosis from year 1, 2 to 3, because lung cancer is so aggressive. And so many of us believe it should probably be annual indefinitely. Regardless, it is absolutely clear that screening improves survival as shown on the prior slide. And so it's important to reflect on how are we doing. And we're actually doing reasonably well relative to other states, but really poorly on an absolute basis. The overwhelming majority of patients who should be screened are not screened, both in North Carolina and in the rest of the country. There are dramatic racial and ethnic disparities in care in the United States in early diagnosis, surgical treatment, and lack of treatment at all. We have those problems as well in North Carolina, but here we're actually doing a bit better than the national average. So I'm going to shift gears a little bit and move to advances that are relevant not only to North Carolina, but to the country as a whole. So for stage 1 and 2 lung cancer, often for the earlier stages of stage 3, we do surgery with a goal of cure. And decades ago, we learned that we could improve survival 5 to 15% or so if we added chemotherapy to surgery. Now, when we add chemo, it turns out that it doesn't matter whether you do it before or after the surgery. The survival advantage is similar. There are probably advantages and disadvantages to each that roughly balance out. In stage 4 disease, which those curves do not reflect, our major advance in recent years is immunotherapy, drugs that stimulate the body's own immune system to attack cancer. And they have a cure rate. They have a cure rate in stage 4 disease. I liken this to pizza. So I'm a recovering New Yorker. I'm very pizza obsessed when I go home. But if I have that first slice of pizza, I'm not satiated. Now I know it's what's possible, what's in front of me, and I'm hungrier for the second slice. And I think that's how we are and should be as a field. We've gotten a taste that we can cure stage 4 cancer when we get it right, but we're unfortunately not doing that often in stage 4 disease. Now, when drugs work in stage 4, they move up to stage 3 and then earlier stages. And that's exactly what's happened here. And actually, immunotherapy seems to get more efficacy the earlier in the disease course you treat the patient. And this is our most recent data, bringing it to before and after surgery. Probably the before is what at least clearly matters the most. And you see a rather large difference here. So the blue curve is patients who got the then standard therapy, surgery, and chemo. The golden curve are those who had immunotherapy added. The x-axis is showing time in months, and the y-axis is showing event-free survival, which is mostly the curve will tick down mostly when cancer recurs or a patient dies from any cause. And you can see that you could drive a Mack truck between those curves, the immunotherapy patients doing dramatically better. And of course, when you cure someone, and when we get this tail to the curve, the flat portion at the right side, and similar agents that have more follow-up have shown longer tails, suggesting it really is cure. That can buy people decades of quality life, not weeks or months, as some of our advances in stage 4 do. So this is a really, really big deal. Now, this is the first, and I think last time I'm going to show you very old data, but I want to show it because it illustrates a principle that's exquisitely important, which is how wonderful targeted therapy is. So targeted therapy, you could think of like a lock and a key model. It has some wonderful human properties that I'm about to explore with you, as long as you match the right target with the right therapy. It doesn't help to give targeted therapy if the target isn't present. That would be like using your key to try to open my front door. You'll just make noise until I call the police. So in the pre-molecular era, a trial was done randomizing lung cancer patients, stage 4 disease, to the then standard chemo, carboplatin and paclitaxel, or the new EGFR inhibitor, gefitinib. Done not because of a knowledge of EGFR mutations, a la 2026, but because it was known that lung cancer can overexpress EGFR. This is a progression-free survival curve. So on the x-axis, you have time in months, and in y-axis, you have progression of being free of progression and death. So anytime a patient dies from any cause or their cancer grows, the curve will tick down. And there's a shape here that is really familiar to any clinical trialist. And that are curves that cross over each other once. So in the early goings, the chemo is doing better. In the late side of the curve, the right side, the targeted therapy is doing better. And any trialist worth her or his salt can tell you that that reflects that you have two populations, one that does better with one drug, one that does better with the other, and that you haven't teased them apart. And when this study was finally divided by presence or absence of EGFR mutation, something really interesting happened. So in the EGFR mutation negative patients, the targeted therapy, the black here, was a diarrhea and rash-inducing placebo. It was worthless. That's what happened. Those curves look like that when you don't treat people at all, whereas chemo was better. But in the patients who have the EGFR mutation, that was our first aha moment about more than 20 years ago now, to see that the targeted therapy beat the pants off chemo. Better progression-free survival. If patients don't cross over, you would have better survival, far fewer side effects. It lasts longer. Responses are deeper. And the cherry on top is that if you're already demedicalizing the patient's life by having less suffering from the cancer and less suffering from side effects, it's particularly nice to then be able to give an oral therapy, which these are. And a lot of the theme, a lot of the theme of advances in the years after that, we're basically repeating the same story again and again, finding more of these molecular changes. Some are mutations, some are fusions, some are gene rearrangements. But the point is, we call them actionable genomic alterations, can lump them together. And that when you have that fit, the story has always been the same. Way less toxic, way more effective, and mostly pills. So this is a patient treated with an EGFR inhibitor. Pre-treatment is on the left, snowstorm chest X-ray. Post-treatment is on the right. And my poll question to you is, what do you think the time interval was between these chest X-rays? So just over half are saying 6 weeks. That is the normal interval, the most common interval on studies to reassess cancer. The answer here is 6 days. And this is not an outlier. This are what we expect with targeted therapies. So I can tell you in my time at UNC, I have twice been called to consult on a MICU patient, new diagnosis, lung cancer, intubated on the ventilator, hypoxic respiratory failure, in patients who didn't smoke. And both of my personal stories are a bit older. When erlotinib was the drug approved in the US, I'll show you a better drug later. But at the time of these two stories, what we had was erlotinib, a first generation TKI, similar in properties to the gefitinib I showed you with the IPASS data earlier. In both cases, we had a G tube surgically implanted to put erlotinib down the G tube. And in both of these cases, we got lucky. The patient had EGFR. And both patients got better so fast that the patient was ready to leave the hospital before they could get a floor bed. So days. And the interns in the MICU had to write discharge summaries, a somewhat rare event, but a very high quality problem. So, and the same we see in clinic every day. When we give a RET inhibitor, when we give an ALK inhibitor, any of these, patients feel better very quickly. The patient knows that the drug is working long before the oncologist does. And the drugs keep getting better. So this is data from the CROWN study. It randomized patients to a first generation ALK inhibitor, obviously people with ALK fusions, to first generation ALK inhibitor crizotinib shown in red, which is better than chemo. There wasn't a chemo arm, but if you had it, it would look worse. And the third generation TKI lorlatinib. And you see that the next generation drugs kick the pants off the first generation drugs. Most of them are less toxic than the first generation drugs. Lorlatinib, unfortunately, is a bit of an exception to that. But most of them penetrate brains, so they control cancer in the brain where the first gen drugs don't. Lorlatinib does succeed there. And then look at those 5-year results. This is metastatic lung cancer. 60% of patients not only alive, but without progression of their cancer after 5 years. And with next-gen inhibitors, these results are becoming more and more common. These are delightful patients to see in clinic because while these drugs are not side effect free, they're much, much closer to it than any chemotherapy ever could be. And patients are, for the most part, living quite well on these agents. They're working, they're taking care of their kids or grandkids, they're traveling, they're doing whatever they care about. And some of them not thinking about cancer much until their scan time comes up, which for most of these drugs, we're doing 4 times a year. I'm not going to go over all of the new targeted therapies. This is just, this is not 3 years as the rest of my deck is oriented around, but the last decade. It's more just to show you the overwhelming list that all these things that were unknown or unactionable in the last 10 years have now changed. And there's only one that I really want to highlight for you here, which is KRAS. KRAS is important. It is the most frequent driver mutation, meaning mutation causing cancer in human lung cancer. And it is the most common driver of human cancer in general. So it's a lot of patients. It's a really big deal. From a chemistry perspective, it's historically been very hard to drug because of its shape, but it's become druggable. So KRAS has multiple isoforms. The first to become druggable happened to be G12C, which is almost as common as EGFR in lung cancer. And there were 2 drugs FDA approved at UNC. We participated in the adagrasib study and saw some of that benefit. Some of our phase 1 patients are still doing well on that. Sotorasib, also a good drug. And there are newer G12C inhibitors that should be coming to market soon that seem to work better, a la the theme I showed you before with lorlatinib and ALK. Excuse me. And the other isoforms are getting druggable. So there are G12D inhibitors that should be coming to market and pan KRAS inhibitors that should be coming to market. And this is a big deal, not only in lung cancer, but in a variety of other human cancers, particularly the GI malignancies where these are very common. There's going to be a massive burden of suffering reduced by the KRAS drugs as they move forward. Others like NRG1 are rare, but nonetheless, we're picking these off one by one. And decreasing the amount of patients that are ineligible for targeted therapy. So I want to talk to you about a trial that really surprised me. The FLAURA2 trial randomized patients with EGFR mutation to osimertinib, the standard of care, or osimertinib plus chemotherapy. The chemotherapy here was pemetrexed and carboplatin times 4, with pemetrexed as maintenance alongside the osimertinib. And I want to ask you, what was the main finding? So this was a trial I was skeptical about. It's a trial that I chose not to participate in. I was skeptical of whether patients really needed the chemo, given how effective osimertinib is. Osimertinib alone, you expect 20-month progression-free survival, and there's a lot of treatment past progression. I've had patients live high-quality years for years after they would have been called a progressor on a trial. We're watching tiny dots become slightly less tiny dots, and the patients are living well without those side effects. There are a bunch of variants on that theme that I won't go over here, but it framed that I was really deeply skeptical about this, and it violates the human story that has so delighted so many of us for so many years that it's nice to not give chemo. We would like to bury chemo. Um, but what I expected is not what happened. So progression-free survival, of course, it was better when you added chemo. The more aggressive a therapy you give, the better you're going to control cancer. That doesn't mean it's worth it or that it's even going to improve survival. And that's why I'm showing you the survival data, which is really hot off the presses, is a pretty new finding. And you're showing a statistically significant and clinically meaningful survival advantage. So it's a 23% improvement in survival, but importantly, those curves are proportional at the tail. Look, that's 4 years out, that last vertical tick mark. The shape is also really interesting, right? You might think that in the early goings, that would be where the chemo advantage was. When you're giving or have just given those first 4 cycles of platinum, it's not at all what's true. The further you get out on the curve, the bigger the distance between those curves. And when they stop splaying, they stay parallel and proportional. So that suggests that there's genuine disease modification here, that perhaps you are randomly obliterating clones in the early goings with chemo that are destined to one day become your resistant clones later. This, to me, conceptually argues that we should perhaps also be doing more consolidative radiotherapy. That once we give whatever we're going to give, whether it's OC or OC chemo, if there are residual spots, perhaps we should be a little more liberal in radiating those spots, that you can actually modulate the course of disease with this. That's a very controversial idea that I won't go into further. If we were having a CME debate, it would be easy to cite data to argue it one way or the other. What is not ambiguous is the advantage of adding chemo in front line. And in considering its human properties, I think it's important to reflect that while carboplatin is real chemotherapy, it is given 4 times, and then patients receive only pemetrexed. Pemetrexed is probably the gentlest chemo known to man. Maybe someone could argue a different one, but I do remember back to the era when we still used it as monotherapy and when erlotinib was still the FDA-approved EGFR inhibitor. I had a series of patients who switched from erlotinib targeted therapy to single-agent pemetrexed, and most of them told me that pemetrexed was actually easier than the erlotinib. Pemetrexed is way better tolerated than most chemo. I don't hate chemo because it's called chemo. I hate chemo because it hurts my patients. And I do think of pemetrexed a little bit differently than most of the other chemo drugs. And that may also play in here, that there was less harm from the chemo in addition to the disease control that was provided. So I've just spent the last 5 or 10 minutes preaching to you about how wonderful targeted therapy is, as long as you're matching the right target with the right targeted therapy. 2 things need to happen in order to achieve that. First, you have to test, and then once you get the test back, you have to actually action the results. There's a huge national problem with both of those. North Carolina is one of the states that does not legally mandate insurance coverage of biomarker testing. American Lung Association calls upon us to change that. I would say, however, that I have never seen a problem in the state of North Carolina. I've never submitted for molecular testing and had insurance deny it. So I'm not sure that we functionally have a problem. But there is a national problem that we are not exempt from, which is there is a roughly 20% non-testing rate for stage 4 adenocarcinoma, the patients that really should have the testing, for EGFR, the oldest known biomarker, and about a 20% non-actioning rate once it is found. I think the non-actioning is better in North Carolina. In my consult practice, I can't remember the last time I saw that for any of the common biomarkers, but non-testing still does happen. This is a major unmet need for education. This is a major unmet need for advocacy. Every patient with stage 4 adenocarcinoma deserves comprehensive molecular testing. I would argue stage 1 through 3 adenocarcinoma as well. And there are certainly some squamous patients in whom it is appropriate. A little bit in the weeds for today, but testing should be done. It should be highly sensitive. It should be highly comprehensive. We have a new class of drugs that have some FDA approvals already in GU cancers and breast cancer, now in EGFR mutated lung cancer. And it's an attempt to make chemo smarter. So antibodies can bind to surface elements of cancer cells. And the idea here is you pick a target present on the surface of the cancer cell for the antibody, and then you decorate it with poison. These have in some cases looked like chemo 1.1, in some cases more like chemo 2.0. I'm not going to go deep into the scientific technical weeds, but I will briefly reflect that disease state, in my opinion, has been the #1 predictor of where ADCs are going to work well. For those who are more scientifically inclined, cancers that are very high expressors of cysteine proteases, particularly cathepsin and L, are going to be good at cleaving this link between the toxin and the antibody, preferentially in the tumor microenvironment. And that may well be why disease state is ending up being the biggest predictor. But theoretically, you also want the antigen to be abundantly present. You want the linker to be cleaved in the right place. And you want the payload to be one that is active against the cancer. And it seems that the higher the ratio of payload to antibody you can get, the better your ratio of kill of cancer cell relative to toxicity. There are multiple disease states where these approved. We have a recent approval for EGFR mutated lung cancer. This was an interesting approval because it was subgroup data. This wasn't a study run in EGFR mutations. So if you look at survival, it's better in the non-squamous patients than the squams, where there doesn't seem to be an advantage. And then patients with actionable genomic alterations, of whom EGFR was the best represented, seem to do yet better. And that's where we have an accelerated approval. I would note, however, that small cell seems to be one of those indications where these work really, really well. It almost doesn't seem to matter what you're targeting. Across the board, these have 50 to 60+% response rates in heavily pretreated small cell lung cancer, which is amazing, and progression-free survivals that are as good or better than 2-drug chemotherapy. I show you the data on IDXD because it's probably going to be the first to market, but there are many others that also have really good data and are moving forward. So I think these are going to be a major advance in the care of extensive stage small cell lung cancer. This drug is also approved, which is why I'm showing it to you. Teliso-V targets MET in non-squamous patients. And so in addition to the sequencing that is now standard of care, optimal care includes getting IHC, not only for PD-L1, but also MET and HER2, which also has a targeted drug. And unfortunately, this is making testing a little more complex, but to the benefit of our patients when we get it right. Here's an advance, though, that I think deserves a little bit more reflection. So in extensive stage small cell lung cancer, meaning incurable small cell lung cancer, our standard of care is 4 cycles of chemo, platinum etoposide, plus the immunotherapy atezolizumab. And after 4 cycles, if the cancer hasn't grown, you continue just the immunotherapy, the atezolizumab. Unfortunately, the cancer grows pretty quickly after you stop the therapy. So we have a high rate of getting response, but we have trouble keeping it. And so what the IMforte study did was randomize patients to no further therapy, so just the atezolizumab that's standard, or the addition to atezolizumab of a new chemo called lurbinectedin. Has its interesting history from the C, but I'll leave that aside for today. So the red curve here was the arm that got only atezolizumab, and that's consistent with prior data on what atezolizumab alone does in maintenance. These curves are starting after the 4 cycles, so they're not going to have the same shape as what you see before. There was chemo that came before, but the red curve got atezolizumab alone. The blue also got lurbinectedin. The curve at left is progression-free survival, our cancer control, and the one at right is survival. On a relative basis, this is large, right? The progression-free hazard ratio is 0.54, so a 46% improvement in progression-free survival. You can see that graphically. A clinically meaningful hazard ratio of 0.73, or 27% improvement in survival. But when I counsel patients about this, including the toxicity that we're going to see on the next slide, many patients reflect on the absolute advantage here. It's 2.6 months on average improvement in survival, and many patients very reasonably say no thank you to taking more chemo for that degree of benefit. Why? Well, chemo medicalizes life, for one thing. You're coming in, I guess you're coming in anyway for the atezolizumab, but it medicalizes life and causes physical harm from its side effects. And these are classic chemo side effects. The red boxes are hematologic events, which really dominate, as well as their downstream sequelae, particularly fatigue, a major source of suffering for the small cell lung cancer patient, if not any cancer patient, but also the classical stuff like nausea and other GI side effects. Now, here's something that I'm much more excited about. So, we're here in North Carolina, so many of you may have heard of CAR. CAR are when we genetically engineer immune T cells to attack a target we want to attack on the surface of the cancer cell. There's a related technology called BiTEs. So antibodies look like a Y, and in an unmodified antibody, both of those sides are going to action the same thing. In a bispecific T cell engager, one side binds the target of interest on the cancer cell, the other side binds CD3. And CD3 is the universal T cell receptor. So what that does is your cancer cell and your T cell are going to be pushed next to each other. And through something called an immune synapse, you're going to basically use any old T cell to kill a DLL3 positive cancer cell. And small cell lung cancer cells almost all express DLL3. So what you're looking at the bottom is a waterfall plot. I apologize, I should have explained this earlier the first time I showed one, but I didn't want to dwell on that product. Every patient who is treated on this trial is a vertical bar. So anything north or above the zero line is growth of cancer. And we define progression as 20% or greater growth by this messed up system called RECIST. And anything that is 30% or more shrinkage, the bar below, the dotted line below, is called response. And this drug, when given to heavily pretreated small cell, which is what you're looking at, has a 40% response rate. That's extraordinary, especially for a non-chemo agent. And interestingly, it doesn't matter how sensitive the cancer has been to chemo before, and it doesn't seem to matter what line you give it in. So what happens to drugs that work really well in late line, which we bring them earlier? And we've seen data on that in two contexts recently. So the Delphi 303 study took patients like the Forte study I showed you earlier, patients who had 4 cycles of platinum, etoposide, and a PD-L1 inhibitor. And these aren't different arms here. You can think of these as one curve on each. They're just which PD-L1 inhibitor they got. And as you can see, they're similar. And gave them, in addition to the standard of care, which was the PD-L1 inhibitor alone, added tarlatamab. And this is absolutely extraordinary. Look at that curve at bottom. That's a year, right? More than 80% of extensive stage small cell lung cancer alive at a year after the chemo. That is absolutely blow away. There's a phase 3 study ongoing, but I think it's not hard to predict heavily that that will be a positive study. Now, with new mechanisms come novel side effects. For those of you who know CAR, they're very CAR-like. Cytokine release syndrome and neurologic side effects, including ICANS. And these are a big deal. Cytokine release syndrome is the combination of fever with low oxygen, hypoxia, and or low blood pressure, hypotension, mostly lower grades, but a really big deal. Because of this, the drug is approved that you have to give the first 2 treatments inpatient. That's because almost all this happens in the first 2 treatments. If the patient does well after that, they're just going to do well. It's an early phenomenon. Once you get them through this, they're fine. But the requirement for admission creates a problem. So if you look at the globe, there's a spectrum of how much there is an association between small cell and low socioeconomic status. And perhaps you've guessed that the United States is number 1 on that list for the association between small cell and lower socioeconomic status. This problem is exacerbated by the size of the United States, right? We are a large country, and many people have to travel a far distance to get to a hospital that's giving this. This is a particularly big problem in the state of North Carolina because we are wide from east to west, and there are only 3 hospitals in the state giving this. And so this product, in my opinion, is absolutely wonderful, but there's a massive unmet need to democratize it, to figure out how to make it available to a larger swath of patients. And there are ongoing efforts to do just that, to figure out how to make it safer and how to give it outpatient. And as a consumer of that data, I really look forward to learning more and look forward to everyone having access to it because I strongly predict that this is going to be approved. Now, a reasonable question is, if it's so great, why not give it starting with cycle 1? And that's been done. We just saw the data on this at World Lung Conference, and it works really, really well. So a top 43% of patients alive and free of progression at a year. This is extensive stage small cell, right? Lung is one of the most aggressive cancers. Small cell is our most aggressive variant. 43% of patients alive and with no progression of disease. Look at that tail of the curve. Look at the right side, right? You're looking at a third of patients tailing off to the extent we have data. And I know this can be long lasting. My first phase 1 patient is still doing fantastic. And look at survival. Again, 80% of patients alive at a year. I wish that was 100, but this is extraordinary compared to what came before. And I predict that while it will come second, I predict this will eventually also be a positive trial in phase 3 and garner approval. If I were king of the universe, we wouldn't be doing a randomized trial on this. Now, of course, our advances, when they work in later stages, move to earlier. I mentioned to you that it's been standard of care for a while to give chemoimmunotherapy, not just chemo, to extensive stage or stage 4 small cell. And so we had a more recent trial randomizing patients with limited stage, the stage where we try to cure but don't do it as often as we would like, randomizing patients to chemo rads alone, chemo and radiation alone, the then standard, shown here in blue, or adding a year of durvalumab, shown in gold. And you can see you'd rather be on the gold curve than the blue curve, but also plenty of room for improvement, which is why we're still working hard as a field. I need to gather myself a little bit for this next slide. So I almost always end my talks to the network or any friendly audience with a picture of my kids. I love showing pictures of my girls, but I actually chose today to show the pictures of someone else's children. And this person has gone public with their story. I'm not telling you anything private here. So that's Ross Kamage with his daughters several years ago. I think that picture was from 2022. Ross is a luminary of our field. More than half of the slides you saw earlier, he contributed in some way to, has made massive contributions to essentially every targeted therapy developed in the last 10 or 20 years, often leading the efforts, and when he hasn't, heavily supporting. He's been a mentor to almost every thoracic oncologist of a certain age, myself included. He is kind, he is generous, he is a fierce patient advocate and has been for a long time. And around the time of this photo, he was diagnosed with stage 4 EGFR mutated adenocarcinoma. And he's really used his experience to try to help us understand the patient experience. He has a unique perspective, having been on both sides of the white coat. And this is a picture several years later of him with his now much older daughters. Years of disease control is the norm with EGFR, thanks to people like Ross. And I just saw him less than a week ago at the Targeted Therapies in Lung Cancer meeting, where he was lecturing, debating, teaching, and contributing further to advances, as he always has done and hopefully will do further into the future. Anyone with lungs can get lung cancer, whether you've smoked, whether you haven't, like Ross, even a lung cancer oncologist, even fairly young patients. It's not fair. Nobody deserves this. We need more funding for lung cancer research so that we can make more advances like those that I've shared with you today. Thank you for your kind attention.
Dr. Weiss, thank you so much. I really appreciate hearing the enthusiasm in your presentation and in your voice as you talk about the new and more effective treatment options that are available to you for your patients. Let me go ahead, and we have some questions coming in, so we'll get to those, and then I have a few of my own if we have time. Let's see, this one should be, there we go. Why are subjects with genetic testing not actionable?
So cancer is a disease of mutations, right? There are many different healthy cells in the adult human body, and cancer happens when one of those cells makes mistakes. We call them mutations, although they're not all actually mutations. If you want to get technical, changes, let's say, that convert that once healthy cell to forget how to do its job and instead learn how to make copies of itself spread and grow. We don't know all of the mutations that cause human cancer, and not all of them do we have drugs for at this time. So when we can find the target and we have a drug for it, that's where we get that aha moment of less target, less toxic, more effective therapies. But if we either don't have a good drug or we don't yet know about the target, that's where targeted therapy is not going to be an option. There is a little more complexity to this. It's also a matter of how good the drugs are. There are most of the drugs are so good that they're frontline drugs, but those first generation KRAS inhibitors, for example, aren't quite meeting the mark. And they're second line drugs. Further, some of these mutations are powerful negative predictors of immune therapy working, while others are not. There's some complexity to this. I tried to keep it simple today, but those are some of the answers to why a patient might not get targeted therapy in the front line.
Great.
So
Thank you.
which three hospitals give it? I believe Novant is the third, if I'm not mistaken. The other two are Duke and UNC. Oh, this is a UNC Lung Cancer Network. Sorry, Durham Community Hospital and UNC. I can't tell, but I'm going to assume everyone's laughing at that attempt at a joke, even if Tim isn't. But the fact that they're at Duke and UNC is problematic because we're only 10 minutes down the road from each other, right? To really get this right, we need to spread geographically across the state. When these drugs were first approved, we knew we would have to give them at the academic centers to start. In the ideal state, though, we had thought maybe we would give the first two cycles, the inpatient ones, maybe a few more after that, just to be sure. And then we wanted to transfer the patients back to their primary oncologists, right? Everybody wins when that happens. Primary oncologist knows the patient wants to see them back. Patients don't like to travel if they don't have to. And while it's a privilege to treat any patient, I wouldn't mind opening up new patient consult slots for patients that I can uniquely help in a different way than the community, either with a treatment like tarlatamab or a clinical trial. And so I think patient, community doc, and academic doc all win when we transfer. Not a single hospital or doc has yet accepted a patient back. And so I think it's incumbent upon those of us who do education and the company that makes the drug to help us with that democratization to get patients back to their homes.
Great. Thank you so much. Towards the beginning, you talked about screening and some of the disappointments with the lack of effective screening. What, in your opinion, would be some ways that we would increase the level of screening in North Carolina?
So I'm just going to say someone commented ECU Health is also giving it. So that's fantastic. Glad to hear that.
Uh, Good.
Further democratization. Thank you, ECU. You're asking about screening. So
Yeah.
there are two answers to doing better with screening. The dominant
Mhm.
one is we need to screen all appropriate patients. There's a heavy stigmatization to lung cancer, particularly amongst folks who've smoked.
Mhm.
It is a social tragedy. Nobody deserves lung cancer, smoking or not.
Mhm.
And it's particularly terrible for healthcare providers to be part of the problem, right? We shouldn't be stigmatizing our patients. We should be supporting and caring for them. I think there are education efforts ongoing. There are creative projects going on in the state to bring screening to the patients, like a van to screen patients. I think that is out of ECU,
Mhm.
if I'm not mistaken.
Yeah.
These are wonderful efforts, but I think we also need to reframe this. Um, Lung cancer is the leading killer of non-smoking women,
Mhm.
right? But there's a very different culture between the leading killer of non-smoking women and the leading
Right.
incident cancer of non-smoking women, which is, say, breast cancer. If
Right.
a primary care doctor does not screen for breast cancer, that is considered malpractice.
Mhm.
And the culture around this, the metrics recorded around mammography are so strong that the primary care docs of my patients with stage 4 lung cancer are trying to do mammograms on them, which makes no sense, right? The
Mhm.
discomfort, there's no purpose once you have stage 4 lung cancer. It's inhumane. But
Mhm.
it's built into the metrics that's considered malpractice. I think we need to shift the culture to think of it the same way in lung cancer. That's not something extra, something wonderful. Good for you. You get a gold star if you
Right.
screen somebody who meets criteria, but that if you're not doing that, that you're not serving your patients properly. The other thing are advances in cancer screening. So there are a lot of exciting ideas about how to improve the sensitivity of testing and to decrease the cost and to make it more convenient. That could widen the swath of patients who are eligible for treatments, maybe one day even including non-smokers. Um, and that might help us to catch cancer at even earlier stages. So there are circulating tumor DNA tests. We just had grand rounds on efforts to reduce the limit of detection, meaning to catch it with even less cancer present.
Right.
And there are breath tests being
Mhm.
evaluated. I can't tell you what the winner is going to be or when, but the technology does seem to be improving over CAT scans. But in the year 2026, the low-hanging fruit is that we should all just do we, meaning doctors, should do what we're supposed to be doing and screen everyone. Screen
Gotcha.
everyone meets criteria.
All right. Well, thank you so much. And thanks for referencing that Cancer Grand Round series. And for those who are interested in the recordings, they can be found in our video library or in our learning portal. So feel free to go there and look at those. I'm going to go ahead and advance to a couple of other slides, and then I'll come back and see if there are any final questions before we wrap up. I do want to thank the state of North Carolina and the people of North Carolina for the funding through the University Cancer Research Fund, through the Lineberger Comprehensive Cancer Center, and the team. And each of the members of the team puts a lot of effort into all of these lectures: Veni Obore, John Powell, Oliver Marth, Andrew Dodge, and Patrick Muscarella, and Kim Riddick. So thank you to them. Thanks to our one audience member who just shared an additional question. So let me go back and bring that one up. And the question is, what's the future direction about how to screen non-smoker lung cancer? Do you think racial demographics should be a part of it? All right. And
You know, there is differential. There are some stats on differential risk by race, as well as on
mhm,
differential treatment of folks of different race and ethnicity.
mhm.
I don't find any of that massive in effect size. The disparities are, particularly in certain states, but in terms of risk, it mostly seems to go with things that co-vary. I think when I think about non-smoking lung cancer, right, you think about the risk benefits of anything you do in medicine, whether it's screening, treatment A versus treatment B, treatment A versus no treatment, right? We're always thinking about what's the probability of helping this person, what's the probability of harming this person. When you screen and you get false positives, there are risks of harm. I think NLST shows us that there can be ways to manage that, to lower that risk for people if you keep to it. I didn't go into all the details of NLST because it's not news anymore, but there were a lot of false positives, and the folks that kept to the strategy the study prescribed, there really wasn't a lot of physical harm, obviously a lot of anxiety. When you get to non-smokers, again, while I've made the points forcefully that anyone can get lung cancer, your probability of finding cancer in an asymptomatic non-smoker drops dramatically. And so when you think about that risk benefit, your benefit it drops off quite a bit, particularly when considered relative to the cost to that person if you get a false positive there. Um, so my answer to this question is that we probably shouldn't be screening non-smokers not generically, regardless of race. Now, people who have some other dramatic risk factor, I think we can use some common sense, right? If someone has a military exposure that's known to cause lung cancer, if someone finds out they lived in a radon-infested home for a decade, I think you can work with a pulmonologist to model risk and engage in some shared decision making with the patient with that information in hand about whether they want to be screened. And I think there's room for some flexibility. But in terms of mass screening, right, bringing this to large numbers of people in primary care, I think we need tests that with better operating characteristics, meaning that they're more likely to find cancer if it's present and more likely to show a negative if it is absent. There are some efforts out there to do this in general, but I think the technology just isn't there yet. So Grail Therapeutics had one such product, and we just saw negative data on that. That doesn't mean we're not going to get there. I think that circulating tumor DNA is still the right idea. I think it just means that it was a little bit premature of a trial. I hope it doesn't shoot the field in the foot with public perception. We need to get the tests really sensitive and really specific. Again, not to overhype our grand rounds, but I think we got a good vision at that talk, which Tim, you can correct me if I'm wrong, I think is still available online. It was Max Dean's talk. That's really happening. That we're getting the limits of detection very far down, that there's new technologies to screen out false positives from technical stuff like chip that can do it. And that the technology really is going to get a lot better. When I think about screening non-smokers, so I've never smoked, right? I wouldn't take a screening test for lung cancer right now. Change my race and I still wouldn't. But when those tests get better, such that I have a little more excitement about them, I'll go out and do it for myself and my family.
Yeah, yeah. All right, thank you. And it's interesting, while you were mentioning it, just seconds before you mentioned radon, we had this other question come in for non-smoking lung cancer. Is there data on the percentage of patients with high radon levels in the home?
I think it exists, but with apologies, I don't know it. So I would encourage Google, or maybe we're now in the era of ChatGPT search, to answer that. I'm sorry that I just don't know.
Oh, no worries at all. And final question, is it true that lung cancer seems to be affecting younger women more frequently than in the past? If yes, what factors do you think are driving this shift?
This has been documented, this phenomenon. I don't know the answer, and I believe the world does not know this answer.
Gotcha. Yeah, I'll reference a lecture from Dr. Hackman a little while back talking about increasing rates of cancer amongst younger individuals, but obviously there's a lot that
I mean, Dr.
needs to be
Hackman is an
discovered.
ENT.
Right.
There is definitely a phenomenon of non-HPV driven, non-smoking driven, non-alcohol driven. We don't know what drives it. Oral cancer amongst young women. They're terrible cancers, and it's really poorly understood. It's an area of active investigation. My opinion is that it's going to be like everything else, that we need to understand it to figure out how to do better.
Yep.
Either prevention or treatment or both.
Yeah, thank you. And very last question, then we really do need to wrap up. You mentioned the lack of access that community patients have to tarlatamab. In your view, what is the next best option for extensive stage patients who don't have access to this drug?
So, small cell is different for me than non-small cell. With non-small cell, I think there's stage 4 non-small cell, there's way too much therapeutic nihilism and far too many patients not treated. That's in general in frontline and certainly across second line and later lines. For the patient who progresses after platinum etoposide and atezolizumab or durvalumab, the frontline therapy, and doesn't have access to tarlatamab, in my practice, I'm talking about tarlatamab, I'm talking about clinical trials, and I'm talking about hospice, right? And trying to match the options with the values of the patient. Unfortunately, trials aren't the best answer for the patient who doesn't have access to tarlatamab. If you can't travel for a trial, you can't travel for tarlatamab. But I think there is room to do better there. I think we need to democratize our trials out to the community. There are lots of efforts to do hybridized, decentralized trials here in North Carolina to bring these options to throughout the state. And that's one answer, trials, but trials closer to home. If you take that away, if you really hold my feet to the fire and make me answer the question as it was probably intended, it depends on the chemo treatment-free interval. So the time from the last dose of chemo until progression is a heavy predictor of the probability of response to next line chemo, whether that next line chemo is repeat a platinum etoposide or whether it's something new like lurbinectedin. There's no magical regression discontinuity. In European trials, they use 90 days. In the US, we use 6 months, but it's actually linear and continuous. If you have a longer chemo treatment-free interval, I think you can use another cytotoxic, either repeating platinum etoposide if it's really long, or in my practice, mostly lurbinectedin. If it's shorter, that patient is really in trouble with standard FDA-approved options other than tarlatamab. And in my opinion, the best options are tarlatamab or a trial, if consistent with the patient's options. And if that's just not possible, then I think hospice needs to be considered, because the probability of response to a late-line approved option like lurbinectedin or topotecan is very, very low. And of course, the toxicity quite real.
Okay, thank you. Well, we are going to go ahead and wrap up. As always, it's really an honor to have you here. We appreciate your dedication to your patients and your wealth of knowledge about your practice. So thank you so much. Thanks to our audience. If you have questions or comments for us, you can follow up at UNCLCN at unc.edu or 919-445-1000. We'll look forward to seeing you at future lectures, and thank you all so much. Take care, everyone. Dr. Weiss, thank you. Really appreciate having you here today.
Pleasure to be here today. Thanks for the opportunity.
Thank you.